Chairwoman Fields, we are live. You can begin when you're ready.
Thank you, Amanda. Good evening. The meeting is now called to order. This is the Health, Aging, and Disability Committee meeting for March 23rd, 2022. I am the committee chair, council member for the 5th District, Brigida Fields. At this time, I will call the roll for those members of the committee first. Vice Chair Maria Cabrera.
Present.
Councilwoman Yolanda McCoy. At large, Councilmember Al Mills.
Present.
Council member for the 3rd District, Xanthia Oliver.
Present.
Council President Trippy Congo. Are there any other council members on the call that are not a part of the committee? Okay. Now we're going to, I just want to send out a friendly reminder. Only members of the committee should be making motions and seconding. Yes, Vice Chair?
I believe Councilman Mills is in the meeting.
Yeah, I just said him. He's a part of the committee.
I'm sorry.
Yeah. That's okay. Thank you. So I'm just gonna, we have an agenda for today. So we have a presentation targeting racial cancer health disparities in Wilmington, Delaware by Christiana Care. Then we have 2 resolutions that's sponsored by committee vice chair, Councilwoman Cabrera. So whenever Dr. Spiegel is ready to start his presentation, you can go ahead, Doctor.
Thank you. And am I sharing my screen or? Okay, I see.
There you go.
So I'll just say advance when someone's advancing it for me, I gather.
Yes, that's correct.
Okay, thank you. Well, thank you for having me here this evening. I work at Christiana Care, and I wanted to share with you work that we've been doing around addressing racial cancer health disparities, specifically in Wilmington. In part, just to share what we're doing, in part because we think there are opportunities to partner and work together on this. So you can advance the slide. You can advance again. So first, let me just define what a cancer health disparity is. So according to the National Cancer Institute, a cancer health disparity can refer to any adverse differences between population groups, whether that be in incidence or the numbers of new cases, prevalence, referring to all existing cancer cases, morbidity, which refers to cancer-related health complications, mortality, cancer deaths or survivorship, so the quality of life, related issues after cancer treatment. Tonight, I'm going to focus mostly on cancer mortality disparities and specifically racial disparities. We can divide populations in lots of ways, but tonight we're going to focus on racial disparities. So what do we know about racial disparities and specifically how cancer affects Black individuals? So from a report released by the American Cancer Society just a few weeks ago, you can see here that the 2 red arrows point to the leading causes of cancer death among Black men and Black women. And for men, it's lung cancer. And for women, just very recently, actually, breast cancer eclipsed lung cancer, which had been #1. So I will focus tonight on our work in both lung and breast cancer because they are the leading causes of cancer death among Black and men and women. You can advance. So what causes disparities? Certainly poor access to prevention, early detection, and treatment healthcare services. But in addition, and we don't really focus on this as much, but greater exposure to carcinogens and other risk factors. And to a degree, inherited genes that predispose individuals towards poor cancer outcomes. Although I'm not going to really speak about that much tonight because that's a factor in only a minority of cases. You can advance. So what are we doing about it? In the first box, you can see there was a recent story done by NPR on how Delaware is shrinking racial gaps in cancer death. through its use of outreach and patient navigators. This was a nice description of the work that Delaware has done historically through community outreach, education, screening, and early detection, mostly in the area of colorectal cancer, to reduce cancer disparities. We actually eliminated those. I'll show you more on that in a bit. But we don't want to just rest on our laurels. We want to go further and go beyond the work in colorectal to see if we can't close those gaps in both breast and lung cancer. So we have new research and new program development focused on that work specifically. You can advance. So this is an article that came out now almost a decade ago about the success here in Delaware geared towards eliminating the mortality disparity between Black and white individuals with colorectal cancer. And I underlined it took a village in the article because I think that was very true then, and I think it will be even more true going forward, that we really do need to work across sectors and work together to have success. And I also highlighted at the time, he was a US House of Representative, but now our governor, John Carney, who was a strong advocate of that work back then. And I would hope could be a supporter of this work too, if we see opportunities to work together in Wilmington. The graph just shows that the difference in mortality over time shrunk. It decreased for everybody, but it was eliminated between African-American and white individuals. And that, I think, is one of the key lessons here as we talk to other stakeholders is, yes, we want to shrink the disparity, but when we do this work, not only can we close the difference, but everybody also benefits as a result. We can advance. So our new directions in terms of targeting breast and lung disparities. And we can go forward. So to focus first on breast cancer, we know nationally that even though white women have a higher incidence rate or more new breast cancers than Black women, their mortality rate nationally is over 40% higher. Here in Delaware, we know that Black women are more likely to be diagnosed with advanced breast cancer, and that Black women in the younger age group, between 40 and 64, according to Delaware state data, have actually a 56% higher mortality rate. We know that Delaware has among the highest rates of a subtype of breast cancer. Breast cancer comes in multiple forms, and triple negative breast cancer is a more aggressive form of breast cancer, and it's about twice as prevalent in Black women as in white women. And we have among the highest rates in the country. And then finally, a report that just came out last year showed that alcohol, which is a risk factor for breast cancer, not everybody is aware of that. It is, in fact, a well-established risk factor for breast cancer. Delaware has the highest rates of what we call alcohol attributable breast cancer, or breast cancer that we believe was at least in part, if not entirely, caused by alcohol use. So you can advance. This is research that we conducted here in Delaware, and we looked at Newcastle County specifically to see what was the spatial distribution of those triple negative breast cancer cases. We know that Delaware, like I said, has among the highest rates in the country. Most of those cases within Delaware are here in Newcastle County. So then we wanted to look even more closely, and we identified two what we call hotspots, or areas where there are a higher number of triple negative cases than you might expect based on the population alone. And there was one hotspot, which is encircled with the red dashed lines that covered much of Wilmington, and then another hotspot down in Bear. There were two cold spots as well, so areas where you saw lower rates of triple negative breast cancer than you might expect in Northwest Newcastle County and in the North Wilmington area. So we know that even within the state that there are areas that we may want to focus on more.
Excuse me,
Yes.
Councilman, Madam Chair, may I ask one question?
Yes, please.
No, I'm looking at the hotspot. Would Dr. Siegel happen to have that zip code? I mean, I can see the area, but is that particular zip code, do you have that area labeled by zip code?
We can supply that. Here, what you see are the outlines refer to census tracts.
Okay, no problem. Thank you.
But I would be happy to cross-reference it to zip codes if you would like and send that to you after the fact.
Thank you.
Okay, so we can advance. So there's a lot going on this slide, and I'll walk you through it, but I think it's important, so just bear with me. So let's focus on the panel A on the left-hand side. So here, we still are looking at that hotspot, but what the darker red areas mean is higher rates of unhealthy alcohol use. And we operationalize that by looking at health record data for alcohol use disorder diagnoses. And so you can see that there's a higher rate of alcohol use disorder in and around Wilmington. The dots, the white dots, refer to liquor stores. And so you can see there's a greater density of liquor stores in and around Wilmington. And we know from prior research that a high density of liquor stores is strongly associated with unhealthy alcohol use. If you look in panel B, instead of looking at alcohol use disorder, we looked at obesity, which is also a breast cancer risk factor. And you could see that there was an elevation of obesity in and around Wilmington. We saw more of that in the other hotspot down in Bear. And the white dots here refer to fast food restaurants, which was not the most precise way of getting at food environment. We're doing some additional research to better understand that. But when people don't have good choices for healthy food options, then we know that we see metabolic outcomes such as obesity tend to be worse. So the takeaway here is that in Wilmington, we saw evidence of both higher rates of unhealthy alcohol use and to a degree obesity, which are both risk factors for breast cancer in general and triple negative specifically. And that some of that may have been largely influenced by what we call the built environment or the retail environment. What are the stores in someone's neighborhood? You can advance the slide. So what do we do with this knowledge? So for one, we can focus our outreach efforts in these hotspots. We already do community outreach as we've discussed, and we can be even more targeted now. So this research helps us to say these are the very neighborhoods that we should really be in, making sure women are aware of risk factors, making sure women have access to screening and treatment if needed. We can also do much more in primary care and in terms of addressing unhealthy alcohol use and obesity. We have really good evidence, in fact, that in primary care clinics, you can work with people who are consuming more alcohol than would be healthy and help them reduce that. One of the reasons I was excited to be able to speak here tonight is there are policy approaches that we can take that really focus on making neighborhoods healthier to further reduce alcohol use and obesity. So there are other cities in the country right now that are testing the effect of policies on, for instance, reducing the numbers of alcohol retailers or liquor stores in a community to see if that impacts not only alcohol use, but some of the other poor outcomes that you see where there's higher density, whether it's pedestrian injuries, car accidents, assault, and that kind of thing. We have a whole nother area of research that we do that's more laboratory based. And I won't get into that too much tonight, but just to say that we are looking to see if there are biomarkers of risk for breast cancer, including triple negative, so that we could do a blood test the same way that we use cholesterol to see if someone's at risk for heart disease. We might be able to use a blood test to see if women are at risk for breast cancer, even before mammogram might pick it up. That's a longer term project, but I just wanted to share that we're also doing that work.
Excuse me, Dr.
Yes.
Siegel, for one moment. Hold on.
Sure.
President Congo, do you have a question?
No, Madam Chair, I just wanted to be recognized.
Thank you. You are recognized. You may
Thank
proceed, Dr. Siegel. Thank you.
Thank you. So then just to shift gears now to talk about lung cancer, the #1 cause of cancer mortality among Black men, and that's true here in Delaware and in the US. We know that Black men have the highest lung cancer mortality rates of any demographic group in the US, and that Black individuals are more likely to present with lung cancer at a younger age and at a more advanced stage, and that Black individuals at high risk for lung cancer are less likely to be advised to receive screening or receive it. So there's a number of disparities that we want to focus on with lung cancer. If you could advance. Here you see a graph that shows the percentage of lung cancer cases that are diagnosed at an advanced stage. It's a general truth in cancer that the earlier the stage, the more treatable it is, but that is particularly true for lung cancer. Unfortunately, absent screening, most lung cancers are diagnosed at an advanced stage. Screening with a low-dose CT scan allows you to detect it at an earlier stage where it's much, much more treatable. And you can see that across age groups, Black men have a higher proportion of lung cancers diagnosed at an advanced stage. Not anybody can be screened for lung cancer. You have to be considered higher risk. So that includes being between the ages of 50 and 80, to have a 20-pack year smoking history, meaning that you've smoked about a pack a day on average for about 20 years. And that either you currently smoke or you have quit within the last 15 years. So the hope is that by increasing screening for Black individuals who are at risk, we can actually shift that percentage down so that more of the detected cases are early stage and treatable. If you could advance, please. But even better than detecting lung cancer at an early stage is preventing it in the first place. And I want to dispel some myths that sometimes I encounter. This, I realize, is a complicated graph, but what it shows you is the probability of individuals taking up smoking in the first place. And each of those separate curves refers to a different generational cohort. And the solid lines refer to Black individuals, the dashed lines to white individuals. What you can see is for every generation, going back to 1900, white individuals have actually taken up smoking at a higher rate than Black individuals have. But if you could advance the slide, what we see here is among those who smoke, the probability that someone will quit. And again, here, the dashed line refers to white individuals, the solid line to Black individuals. And we see that even though Black individuals are less likely to take up smoking, among those who do, they are less likely to quit than white individuals. And this holds up across generations as well. And what this does as a net result is it leads to a greater overall exposure to carcinogens among Black individuals who smoke. If you could advance, please. So why are smoking cessation rates lower among Black compared to white individuals? Well, we know that physicians are less likely to advise Black individuals to quit or provide smoking cessation treatment. Also importantly, when the treatment is provided, treatments seem to be less effective for Black compared to white individuals. Similar to the alcohol retailer issue with breast cancer, we also know that if you live in a neighborhood with a high density of tobacco retailers or stores licensed to sell tobacco products, that reduces the odds of quitting by about half. It's pretty significant. And we believe that's because you're constantly being exposed to cues to smoke. Even among individuals who want to quit, it makes it much harder to do so. If you could advance. There was a recent book published just a few months ago by a Princeton historian, Keith Waylu, called Pushing Cool, and he goes through a lot of historical documents to show just how hard the tobacco industry has really focused on predominantly Black urban environments to market their products, particularly after 1970, when advertising by TV and radio and then ultimately by billboards was prohibited. They really moved into the urban setting and used the storefront as the primary way of advertising. If you could advance. And so here I want to show you a few maps of research we've done here in Newcastle County that I think you don't really need a statistician to explain to you what we're seeing. On the left is where the stores licensed to sell tobacco retailers are. The darker the red, the more tobacco retailers there are. On the right are the darker the red, the more people who smoke. So you don't need to do formal tests to see that there's a pretty strong correlation here between where the retailers are and where people are who smoke. Now, a lot of times I get the question, well, this is a chicken or egg question. Are there more stores because there are more people who want to smoke, or do more stores lead to more smokers? We have a lot of evidence to suggest that the tobacco industry is being very purposeful in creating and maintaining markets, and that if you were to remove stores, you would see people stop smoking or reduce the likelihood that young, adolescents or young adults would take it up in the first place. And I can elaborate on that if people are interested. Next slide. This is a similar type of map, except here I'm showing you with the black dots where the tobacco retailers are. And then the darker the red area around the black dot shows you the probability that the person who lives there is going to be a current smoker. So you can see that living in close proximity to tobacco retailers leads to a greater likelihood of being a current smoker, and that because there's a much higher density in Wilmington, that we see a higher rate of individuals who smoke. If you could advance. One last map. This is just Wilmington, and what we wanted to do is understand where are these tobacco retailers. Sometimes I've gotten some pushback from individuals saying, well, Wilmington is the biggest city in Newcastle County. There's a large commercial district. You just should expect more businesses there. But what we did is we looked by zoning, and what we found was that a very large share of tobacco retailers are actually in residentially zoned areas, particularly medium and high density residentially zoned areas. So these are, the corner stores, the places where people have to go to buy their daily food or bread for the week, or, the places that kids are walking past on their way to school. It's integrated into people's neighborhoods. I don't need to tell this audience, you can see in the community what this map is showing. And so it makes it even more pernicious than what we see in other parts of the county, where you may see, tobacco retailers, but they tend to be they're primarily in commercial districts and strip malls, places that people don't have to walk past. You have to search it out if you want to get it. It's much less of a cue to smoke. So if you could proceed. There's a lot going on here. I probably don't have time to elaborate on this, but I wanted to share other research that we have. I mentioned earlier that, the treatments for smoking cessation, which include medication and counseling, don't seem to be as effective for Black compared to white individuals. Part of that is because it's hard to quit when you're being exposed to cues to smoke. But we also have research to show that we can improve upon those quit rates by personalizing treatment. People metabolize nicotine at different rates, and with a simple blood test, we can determine how quickly you metabolize nicotine and then make a specific medication recommendation. And so for people who happen to be fast metabolizers of nicotine, this is a group who has greater difficulty quitting in general. But if we pair you to the right medication, then we can increase quit rates by as much as 5 times. So there is more we can do on the treatment side as well as on the policy neighborhood side. One important policy issue I might mention is, so the medication varenicline is the generic name. Right now, Delaware Medicaid requires that patients fail nicotine replacement therapy. So for example, the patch, in order to qualify for varenicline. And if we know from a blood test that you're much more likely to succeed on varenicline, this might be another policy issue to consider. Do we have to require people to fail before we can provide them a more effective treatment? It's something I would be happy to discuss further too if there are questions. If you could advance the slide, please. So what do we do with this knowledge? Well, for one, we want to increase equity in terms of access to lung cancer screening. And between the lung cancer screening and also breast cancer screening that I mentioned earlier, we're right now working on developing improved access to prevention and early detection services out of Wilmington Hospital, just for that purpose. We can also increase access to smoking cessation treatment and offer personalized treatment to improve outcomes. We can consider policy approaches to further reduce smoking. And again, there are other cities in the country that are setting policies to reduce the number of stores licensed to sell tobacco, to reduce the number of people smoking in the community. And just like we have biomarkers with blood tests to identify people at risk for breast cancer, that's research underway. We're doing something similar with lung cancer, so that in tandem with the lung cancer screening, the CT scans, we might be able to get even more precise about who's at risk. And if you could advance. So in conclusion, advance please. We have what I would call a new playbook. Targeted outreach to improve access for screening and risk reduction. Policy approaches we can consider to make neighborhoods healthier, and then research to continually improve upon our current approaches. And one more slide, please. Here's a headline from CNN a little while back which called Delaware a model for addressing small scale disparities. And here small scale refers to small in terms of geographic area, but not small in terms of the impact we're having on people's lives. And so Delaware has received prior national attention for our success in the colorectal cancer work that I mentioned earlier. We have a track record, and we are committed to reducing racial cancer health disparities for other cancers. We have our new playbook, and I think the only thing holding us back, other than just will, is that we really do require strong partnerships, resources, and policies. So I'm excited by the opportunity to work with policymakers and government officials, and I'm happy to be here speaking with you tonight for that reason. So with that, that concludes my presentation, but I'm happy to take any questions. I think you're on mute.
I'm sorry. First of all, I'd definitely like to acknowledge Councilwoman McCoy. Thank you for joining.
Thank you.
You're welcome. Okay, yes. Councilman Mills.
Yes, good afternoon. Thank you. And thank you for the presentation, Doc. Quick question. You mentioned a number of cities that are doing something in the reduction of retailers.
Yes.
Yes. And do you know, can you mention those cities?
So for alcohol, the one that I think is the furthest along is Baltimore, actually.
Okay.
And then for tobacco, there's actually more who are working at this. San Francisco is among, I think, the first major city to work on this. New York, I think they did either something in New York City, or they may have even done something statewide. But Philadelphia has had the most success. They weren't the first to it, but they've taken the most comprehensive approach. So we actually are neighbored on either side for both the alcohol and tobacco retailer reduction policies.
All right, thank you. And the follow-up, in reference to the Medicaid and having to fail in order to receive the second part of the sensation.
Mm-hmm.
And how long is that requirement? If once they failed, is it a time period they have to wait a certain amount of months or years before?
No, I don't think they have to, so I think the policy comes from a well-intended place. Of course, there's a real price difference between nicotine replacement and varenicline. And so if they're comparable, of course, you would encourage people to try the less expensive option. But what we know is that they're not comparable, at least for certain subgroups. And so it's my understanding that before you can get the authorization to try varenicline, you have to at least gone through one documented attempt. And then if you have and you've not been successful at quitting, then I think you can then qualify. The research is there, to support this. It's just, I think, making people aware and just opening it up for conversation to see if that's a policy change we might consider.
All right. Thank you.
And I've shared this, by the way, with the Delaware Legislative Black Caucus as well, because I know that there's different levels of policy making. But I thought I might mention it here today because a lot of the population we're talking about is in Wilmington.
Is in Wilmington. Great. Yes. All right. Thank you for your time. Thank you, Madam Chair.
You're welcome. Councilwoman Cabrera.
Thank you, Madam Chair. First of all, I want to thank you for this comprehensive presentation. I think it's so important. You're bringing to attention something that is very real, and the numbers are a bit shocking. So as some of us might already know that certain things lead to this in these communities, we know that a lot of the target marketing for some of these products happen in those communities. So you tying in the racial disparities with health to that also adds to what we have been trying to work on and advocate to limit that type of advertising in those communities, and to even limit the amount of those liquor stores and certain businesses in our neighborhood that do that advertising. With that said, aside from that type of legislation where we can start limiting these types of businesses in the neighborhood, what else would you like to see that we could sponsor to help move this initiative over? Understanding, or push it up, understanding that some of it does have to be done on a state level. I personally had worked with the anti-tobacco campaign and the cancer campaign, and I know that those were very effective. A lot of dollars went into that to really push forward the message. Are those resources available, and what can we do to help get the word out about this within our prospective communities?
No, I appreciate the question, and I agree. So any policy approach has to happen at multiple levels. From a retailer standpoint, though, a novel approach is to consider the use of zoning, which would be in the purview of the city. I think it's important to say, so tobacco control has been described as the most successful public health initiative in the 20th century. We went from a time in the 50s when nearly half of all adults smoked to a point now where across the country it's about 13, 14%. That's a wild success. The problem is that that success was not equally enjoyed, that lower income individuals and urban people living in urban settings and areas that are made up of predominantly ethnic and racial minorities, we haven't seen that same success. So I think there's an argument to be made for municipalities and cities to exercise the authorities they have to protect their own residents. And that's not something that's probably going to come from a state level, because at a state level, tobacco control, while important, it's not as big of a problem as we see it in certain hotspot areas, as I tried to show. So I think that the use of zoning is one novel approach that hasn't always been considered in the tobacco control world. And then we're starting to see it happen in the alcohol retailer situation. In the tobacco, some of the focus these days in the larger tobacco control efforts is around flavor bans. There's also, so that's for e-cigarettes. And then there's also continues to be conversation about menthol flavor bans for even traditional cigarettes. That's probably something that has to happen at a federal level. It's been proposed before, but knocked down for a variety of reasons. There's a very interesting history there. But I think that in addition to thinking about reducing exposure to harmful products, thinking about what goes in its place. So in Philadelphia, they have this corner store initiative, not all too different from what has been attempted in Wilmington, but that, in addition to offering healthier foods and other healthier products, they work with owners to reduce the number of tobacco products. I think that there's, of course, there's going to be people who see it very differently than what I'm proposing. These are local business owners, people who are trying to pay their bills. If we take away sources of revenue, how are they going to cover their expenses? And I'm sympathetic to that. I think there are ways that you can work with these local business owners to make them whole. There's a lot of money collected out of Wilmington in the form of tobacco taxes. There's also settlement dollars that come to the state. And, I think we're in the $100 to $150 million range when you combine those two sources of revenue. I know that there's also other funds that the state has received related to COVID. And we know that things like tobacco and alcohol use have both been negatively impacted by COVID and also make people more susceptible to COVID. So I think there are ways to work with local business owners to help them be whole, but really move them towards how do you help make for a healthier community and continue to be, viable as a business. So those are some of the things that I realize these are sensitive and delicate issues, but I've been working at the Helen Graham Cancer Center for 15 years, and I've spent a lot of time with families who are saying goodbye to loved ones. And I can tell you that that's also a very delicate issue. So I feel like we should probably have these difficult conversations.
Thank you. Council, any more questions, Councilwoman Cabrera?
Yes, I actually did want to follow up on that. When you say it could be harmful to businesses, one of the things that one of our council members, Councilwoman Darby, was trying to put forth was to make sure that in these impacted communities, that the advertising of the alcohol cannot take up more than a certain percentage of the window. So that is something that we were looking at. And I understand that part. It's not that we want to do away with corner stores, but I think that they do get a kickback of funding for advertising these products. So what you're saying that that there are resources from different sources? Are you saying that maybe instead of them getting that kickback or that subsidized money from advertising the tobacco, that there could be funding that they could get from the state for not advertising the tobacco? That way they're not losing that revenue. Is that something we can explore, or does that exist?
Yeah, that's exactly so it's not for me to make policy. I just want to make everybody aware of what has been looked at elsewhere so that you can make your own decisions for your community. But yes, when it comes to liquor stores, there's much less documentation. But when it comes to tobacco stores, because of that master settlement, there was all these internal documents that were turned over and have now been studied. And what we know is that the tobacco industry pays these local businesses for shelf space. And beginning in the 1970s, when the bans were placed on TV and radio advertising, which was a large amount of, at the time they banned tobacco commercials on TV, that was the number one source of revenue for TV stations for advertising. There was a huge amount of money. They did not stop spending the same amount of money on marketing. Instead, the tobacco industry shifted those dollars into these stores. And a lot of it is at giving kickbacks or rebates so that stores can not only preserve shelf space, but also keep the price of tobacco products lower than they otherwise might be. So that negates some of the effect of taxing these products. So yeah, I mean, if on the one hand, you as a store owner have an industry paying you to sell their product, and then you have someone else coming along saying, we don't think you should do that, money talks, but it also helps them pay their bills. So I think if you look to the history, we started to work with those who grew tobacco crops and said, we're going to help you transition to selling other crops. I think you can take a similar mindset for local businesses. It's been done a couple of different ways. It's been done through mandate, but it's also in San Francisco. They set up a program which was grassroots based, and where store owners actually volunteered into this because there were incentives to stop selling tobacco products. They saw the value of doing that. So there's a lot of details here. And again, I'm happy to have follow-up conversations or send materials if that would be helpful. But I just wanted to more kind of spark some interest in what other areas have done so that maybe we can apply some of those lessons learned here.
Thank you. Thank you.
Thank
That's it,
you.
Madam Chair.
You're welcome. Councilwoman McCoy?
Thank you, Madam Chair. So I'd like to ask whether or not the graphs that you showed us, whether or not the people who were actually surveyed, were they are tobacco smokers only, or were they just smokers, period? Because we do have the e-cigarettes.
Oh, right.
Like somebody smoke marijuana. Like I just wanted to find out whether or not this was like tobacco only.
So what in the maps we showed you, those were people who reported to smoke regularly traditional cigarettes. So
Okay.
not included, we didn't have data on e-cigarettes or other products that they might smoke, because it's a requirement that we ask our patients if they smoke traditional cigarettes. It's not necessarily a requirement to get at those other products.
Okay. May I follow up, Madam Chair?
Yes.
Okay, thank you. All right, so the other question was, Councilman Cabrera actually touched on this a bit, and it was about the advertisement. So the thing was that when it comes to liquor stores, we understood, liquor stores actually were selling alcohol or whatever, and if they wanted to show you what type of merchandise, whatever they have within their walls, they will put this sign up. We tried to target advertisement for cigarettes on the liquor store that they should not be shown. I also had started where we don't see tobacco products on television. I actually brought proof where I got something in the mail from Jewel, and I seen something on TV for View or something like that. So they're not advertising cigarettes, but they're advertising e-cigs on television.
The difference between nicotine and tobacco. So so tobacco is regulated, but the e-cigarette companies have, which by the way, the tobacco industry have largely bought up, have tried to get around that by saying we're not selling tobacco, we're just selling products with nicotine, which is the active, ingredient that is addictive.
Okay, thank you for clearing that up. And let me see, what's the other thing? Okay, I didn't know whether or not you were, but when it came to some ordinances that was passed here within Wilmington, I actually had created one, and that was about tobacco placement. I felt as though we had an obligation we were pushing tobacco on our children, because anything that you could put tobacco in, cigarettes, pipes, cigars, and all that kind of stuff, were basically placed right in plain view at all of the corner stores.
Right.
And so I had created an ordinance, so that actually had to be moved in the back behind the clerk.
Mhm.
But so my question is, like, when it came to, as we stopped being able to smoke publicly,
Mhm.
wanted to find out whether or not, and when I say publicly, like smoking in public places, you
Mhm.
can still smoke outside. Delaware, I remember when all of this happened, because I think I was a smoker at that time.
Mhm.
Did our smoking decrease during that time frame when we eliminated smoking in public places, and has it increased again since that time span is gone? That's been more than 20 years now, I think.
Yeah, with Ruth Ann Minner, it was controversial at the time, but now we don't think
Yes.
twice about it. Yeah, so that had there were multiple initiatives at the same time happening at the state and the national level. But yes, we definitely saw that appeared to have a significant impact, a positive impact on smoking rates. They declined. The concern right now is that the decline has slowed. So no, we're not seeing it go back up, but it's not going down at the rate that we hope it to. And so smoking, and I don't think we can say this enough, continues to be the number one preventable cause of death in this country. We're talking about between 400,000 and 500,000 lives every year. That's comparable to what COVID did last year. COVID's terrible. It deserves all the attention we need to give it. But smoking has been doing that every year, and it will continue to do that, hopefully long after COVID is done, but it will continue to take lives unless we innovate, because if we just continue with our current tobacco control, we're going to see that continue on.
Thank you. I have no more questions.
Thank you, Councilwoman McCoy. I do see we have someone out in the public. Is that right, Amanda?
Yes, there is one person for public comment.
Okay, Alexo. Are they still there?
Yes, it looks like we're going to have to move them to the panelist side. They are not on a current version of Zoom, so I will try that.
Thank you.
1 second.
While you're doing that, if anybody wants to, you have my email. I'm happy to, if anyone wants to follow up, I can answer questions, or we can set up additional time if people had wanted to talk further.
Sounds good. Lexi, are you there?
Yeah, I'm here. Can you hear me?
Yes, I can. Thank you.
Okay. I'm wondering if you guys have updated the mental health statistics, because I know Delaware has one of the highest mental health statistics per capita. And I know that mental health also plays a part in alcohol and tobacco and drug addiction, and a lot of recovering addicts and other people, they smoke cigarettes and stuff like that. And I'm wondering if mental health should be something we should be focused on as well. And it is passed down through genetics, just like cancer and everything.
So I had a little trouble hearing, but I think I got the gist of it. So yes, we know that individuals who have mental illness in
Did you
particular.
get that?
Yes, we can hear you, Lexi.
Yeah. So serious mental illness in particular, we see higher rates of smoking for sure. Historically, we have not addressed smoking among people with mental illness. We've often treated that as secondary, but we know that if you treat the smoking, mental health improves. And also, people who have serious mental illness have a reduced life expectancy, but it's not the mental illness that's killing them in most cases. It's the use of tobacco and other substances. Yeah. So
Yeah.
absolutely, you're right to point out the importance of mental health. And if we were going to talk a little more, we could talk about what are things that we should do to increase access to mental health services.
Well, I don't know if you know about Dr. Saeed. He's dead now, but he had done like a all natural process. He was giving his patients remedies with like vitamins and stuff like that. And unfortunately, he's passed away, but he had very good outcomes with helping people recover from diabetes, cancer, AIDS, HIV, addiction, depression, mental health, and it was more so he was forced, you know what I mean, to have to leave this world. But like he had some really good ways to help treat these kind of things, and I feel as though maybe we should look into those kind of treatments. It's more all naturals and what's it, when you fast and just stuff like that. But it had very good rate.
Well, Lexi, thank you so much for calling in. We really appreciate your call and your questions. He is going,
That's
Dr.
it, I'm done.
Yeah, Dr. Siegel, he is going to leave his information in the chat, so you can definitely email him or call. I'm gonna email him, or whatever he gives out for you to contact him, discuss a little bit further. Thank you so much.
Hello?
Oh, shoot. Can you hear me? Okay, he put his information in the chat, Lexi. Are there any more questions for Dr. Siegel from council? Okay, Dr. Siegel, as the chair, I just want to say thank you so much for coming tonight and doing your presentation. You definitely gave me some things to read up on, and you gave me some knowledge on. I didn't even know that alcohol played a part into to cancer. I had no idea. And I also want to give a recognition to Miss Nora too. I seen her on your article as well. And she's one of our major community partners throughout the city of Wilmington. So I was just happy to see that she was a part of the same article that you were speaking from. Other than that, you did give us your information, and we appreciate your presentation, and we hope to see you back soon.
Thank you very much.
Thank you so much for attending.
Have a great evening.
You do the same as well. Thanks. Okay, our next agenda item, we have two resolutions being sponsored by Councilwoman Cabrera.
Okay, I will proceed. Thank you, Madam Chair. And let me know if you don't hear me, because I see the connection's a little spotty over here in the council office. The first resolution that I'm presenting, it is sponsored by Representative Griffith. It's House Bill 317, and it's a resolution to the Delaware General Assembly in support of House Bill 317 for creation of a health coverage system to ensure Delaware children are insured regardless of undocumented status or other disqualifying factors. So basically, the bill is the Cover All Delaware Children Act. This act directs the Department of Social Services to develop and operate a medical coverage program for children in Delaware who are not otherwise covered, including children who are not documented in bases that would keep them from qualifying for Medicaid or CHIP coverage. But it is not eligible for Medicaid or other funded coverage. And they're eligible for coverage under this medical care, under this act. And this would be effective for January 2023. So if this were to pass, it would be inclusive of all children being able to get medical care. For a family who gets the expenditure of at least $400 in 1 month, could literally, because they're usually low income, could really knock it out. And it does put vulnerable people at a higher risk of medical complications, which would be more costly for us in tax dollars. So 64% of Americans report that $400 in unexpected expenses can cause financial hardship. So with this bill, it really would be all inclusive of children being able to be covered regardless of their documentation status. And that would be House Bill 317. Any questions from my colleagues? And if there are no questions, Madam Chair, let me know if you need me to proceed to the next one.
Yes, please proceed.
Okay. The second resolution is House Bill 303, and that is sponsored by Representative Longhurst. And that is a resolution to the Delaware General Assembly in support of House Bill 303, requiring coverage of annual behavioral health exams by insurance providers. Having been in the forefront of the Affordable Care Act as a navigator and making sure that people got health insurance up and down the states, this is really important. We know that the Affordable Care Act makes it law that every insurance company has to provide 100% of preventative care. It does not matter what level insurance you have, even the most basic has to cover everything that is preventative. When we look around us in our society, a lot of the situations that we see occurring, and now more than ever because of the mental distress that COVID has caused, including in our children. Think about the shootings, think about the state of mind that a lot of these people are in. And in many occasions, no one has diagnosed them for whatever issue they might have. So if you did include that all health insurance companies have to include that mental health or that behavioral health evaluation, think of all the tragedies that we could present, and by giving people the help and the assistance that they need. I'm glad that our country and our society is moving away from the stigmatism of mental health, and now that it is a discussion that we have more freely. There are still people who will not engage, who feel that that stigmatism, they'll use words like crazy, they associate it as being something negative, when at the end of the day, we have a complete body and our mind is what actually runs our body. So for us not to be of sound mind and not to get the assistance that we need for whatever might be happening, including even disbalances with chemicals, think of all the things that we could prevent if we were able to provide and catch people at an early stage and provide them the mental health services they need, including our children, because we're seeing this now more than ever. So I think that these are, two good resolutions that we as council can support, that are in Dover, and help our colleagues down there continue to pass legislation that is going to benefit all of our communities. That is it, Madam Chair.
Thank you, Councilwoman Cabrera. Since these are two resolutions, they don't have to be voted on. Will they be on the next city council meeting?
Yes, Madam Chair, they would be. I don't have an exact date here. It doesn't state when they're going to be on there, but I imagine that it would. And if any council colleagues have questions or would like to be co-sponsors, they're more than welcome.
I would like to be a co-chair for both, please.
I would like to be co-chairs as well. Thank you.
Thank you both.
You're welcome. Okay. Since there's no more business and our agenda has, we've reached our agenda. This time we can, is there a motion to adjourn?
So moved.
Second.
Okay. It's been properly moved and second to adjourn. All those in favor say aye.
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 Those opposed? Motion carried. Have a good evening, everyone. Thank you.
Good
Thank you.
night.
Bye. Good
Good
meeting.
night.